Today we are talking to Dr. Sonia Bansal, of Assistant Professor of Psychiatry at the University of Maryland School of Medicine and Maryland Psychiatric Research Center. She recently published a paper entitled Association Between Failures in Perceptual Updating and the Severity of Psychosis in Schizophrenia in the Journal of American Medicine in January of 2022. So thank you for talking with us today and spending some time discussing your work. So my first question is just basic. How did you get into doing research? And more specifically, how did you transition into research on schizophrenia?
Sure. I think basically during my undergraduate days, I got exposed to some animal models of autism and Alzheimer's disease. So that got me interested in the research aspect and specifically kind of the psychopathology side of things. And after my undergraduate, I thankfully got a post-bac position at the Veterans Affairs Medical Center in Washington, D.C. And part of my work there was with veterans who had schizophrenia. And so that got me looking more at cognitive behavior and perceptual behavior in veterans with schizophrenia using a variety of methods, and continued along that trajectory to work more on that stuff during my PhD as well.
Okay, so you've been working on it for
it's been a while, yes.
So what are the larger research questions that you seek to answer within this field?
So I'd like to think of myself more as so my PhD is in neuroscience. I'd like to think of myself more as a cognitive neuroscientist. So I basically kind of translate things I have experience with in visual perception and kind of sensory systems, and try to look at what goes awry in those systems in psychosis. So some of the bigger questions I would like to answer are just how people with psychosis interact with the environment and how their perception of the outcomes of their sensory experiences affects their behavior. And along those lines, how the cognitive system is able to kind of override some of these sensations to produce certain behaviors. So, and that is all kind of related to things like hallucinations and delusions and belief formation and kind of how that interacts with sensory systems.
Okay, that makes sense. So this paper specifically was working within like a clinical setting and working with people with schizophrenia and schizoaffective disorder. So is that primarily where you work within the field of using actual people in the research, or do you use mixed models?
Yeah, so I primarily work with kind of first person's accounts of their experiences and psychophysical computer tasks, as well as using recordings of their brain waves using EEG, electrophysiological recordings.
Right.
So we track kind of brain activity with that. But primarily, especially with regards to things like hallucinations and delusions, what I personally really enjoy doing is kind of presenting people with very simple tasks that can tap into basic mechanisms of how they interact with sensory stimuli. And it taps into not necessarily higher order cognitive mechanisms like strategizing, but more just initial perceptual responses to these stimuli. So that's where the psychophysical aspect and kind of signal detection type tasks come in. Mm-hmm. So I use those methods mostly with people who have schizophrenia and comparison healthy populations as well.
So is there like a challenge to get people enrolled and keep people enrolled to conduct these trials and tests?
Thankfully, where I am now at the Maryland Psychiatric Research Center, we have a pool of participants that have been coming in for treatment as well as research for a very long time. And that pool kind of keeps getting replenished. So it's a pretty well-oiled system. So personally, while it's difficult to test patients who are unmedicated for stability reasons, patients who are on medications are pretty regular, and we have a good pool of those participants.
Okay.
Well,
Well,
I guess I'm lucky in that regard, which is not true for everyone in psychosis research. So
yeah,
I would not generalize that.
yeah. No, it seems like once it's set up well, it can run well. But yeah, that initial setup can be quite the burden. So can you describe the major findings of this paper for the audience?
Sure. So as I mentioned, I'm very interested in using very simple perceptual stimuli that doesn't require any kind of strategizing or complicated cognitive function. So in this task, we were basically testing the idea that comes from a framework where with healthy people as well as people with psychosis, our brain is thought of as this inference machine that is kind of using prior experiences and prior beliefs to match up to any incoming sensory evidence and form new beliefs or update beliefs accordingly. So while testing that requires, higher order mechanisms as well, it can also be done with a very simple task. And in our case, we used a motion coherence task in which there are, it's called a random dot kinetogram. And this has been used in monkey studies to look at motion coherence. And it's very well kind of mapped out as far as the neurophysiological underpinnings go. So this task basically assesses the visual perception of motion. And so in terms of being able to kind of update your percept, what we did is we had moving dots in one direction, and then midway through the trial, they changed direction by 90 degrees. And the moving dots are kind of the signal in noise, in the sense a certain proportion of the dots are moving in the same direction at the same point, while the others are all random. So it adds an element of uncertainty and being able to perceive motion in spite of the uncertainty, and then update to perceive the changed motion during the second half of the trial. So the task for participants was to basically report the motion direction at the end of the trial. So in this case, we're assessing their perception of initial motion and then being able to determine the change direction as well. And so what we found is that people with psychosis were more frequently reporting the initial direction of motion of the dots rather than the motion at the end of the trial. And this kind of assayed the failure to update in light of new sensory evidence. And this was related to symptoms of psychosis, such as hallucinations and delusions as well. So that was kind of the overall picture. And basically the task was, used to show that using very simple stimuli, you can get at this failure to update or integrate information over time.
So how does that failure to integrate new information, how does that actually translate to everyday life or clinical symptoms of the people who have schizophrenia?
So in terms of failure to update, it may be things like having very tenaciously held beliefs, and in light of new evidence, not being able to budge from those beliefs. Yeah. So kind of if you associate a certain perhaps negative stimulus to an experience, a past possibly traumatic experience, the failure to update can result in perhaps things like paranoia, in terms of not being able to update your beliefs to dissociate the negative aspect. And that's more on a higher order level.
Okay.
But in terms of just visual perception and being able to update certain sensory evidence in day-to-day life, that's what this task kind of taps into.
So is this task, the moving dot test that you use, something that's already used as a clinical assessment, or if not, can it be adopted rapidly so that the correlation can be looked at like on a wider scale?
So the actual stimuli, the random dot kinetogram, which is the moving dots within a circular aperture, that has been used multiple times in animals as well. The aspect of the change motion has not been used much. And there are various other versions of it where people are to report, it's a forced choice response. So they're asked to report whether it just changed clockwise or counterclockwise. I guess the novelty of our version is that we're actually getting an assay of the precision via response errors. So we're getting, not just the bias of being more heavily weighting the initial evidence, it's also kind of precision measures. So these aspects are the novel piece, but the actual moving dot stimuli is pretty well used in the field of visual perception and psychophysics. As far as use for clinical assessment, since it's one of just 2 or 3 studies that have used this in clinical populations, it would have to be kind of well validated, tested out in larger samples, and the robustness of the correlations with symptoms would have to be shown multiple times. But hopefully this is a step in that direction, especially considering we were able to replicate it in 2 different samples across 2 different sites. So
and it's a computer program, right? So it's pretty easy to run. Okay.
Yeah. In fact, we are working on an online web-based version that could be used more widely. So
yeah, okay. Yeah, that makes sense. So one thing that I noticed in the the demographics of the people enrolled in the study was that I think it was 65% men. Is that the typical breakdown for schizophrenia? There's more men than women, or is that just of a sampling?
Yeah, that's pretty typical, especially among the kind of within our pool at MPRC. That's pretty typical across all the studies, unfortunately. But I think as we move forward with more consideration of balancing these kind of demographics, we try to target recruitment accordingly. So hopefully improvement in future studies.
Yeah, that's
but thankfully with testing out very simplistic kind of perceptual function, gender is not a factor for the most part.
Okay.
So that's useful, but at the same time, it would be better to consider more balanced samples.
So what area of the current assessments that are being used to understand psychosis in schizophrenia need improvement to aid the better diagnosis, treatment, or understanding writ large?
I think one of the things in my experience recently is there's been more discussion on, especially with symptoms of psychosis like delusions and somewhat relatedly like paranoia as well. In terms of improving assessments of those, there's been more discussion on taking kind of cultural and socioeconomic factors into consideration so as to not impose some kind of bias in these kind of assessments, especially with things like suspiciousness and paranoia, where certain neighborhoods or certain kind of socioeconomic status or race may be assessed very differently. So there's that that needs to be improved, in my opinion. And in terms of, research and kind of very basic psychophysical tasks or neuroimaging and other assays of brain function, I mean, this is probably a big buzzword, but being able to replicate is
Yeah.
kind of, yeah. So there's that as well. And I guess in the field, a lot of movement is towards computational psychiatry as well. So some of these behavioral tasks, the improvement for those would be kind of getting at the neural mechanisms and how computational psychiatry can be used to aid in modeling neural function with this kind of stuff. And that would then possibly be useful for predictive function as well. So
that kind of gets at my next question. Kind of zooming out, what do you think the exciting research that's coming out in your field is in, and what areas do you think need more investigation in the field as a whole?
In terms of methods, as I mentioned, I think the computational aspect is pretty exciting, pretty useful, has high predictive power depending on how it's used. And in terms of, I guess, if you could just repeat the second part of that question.
What do you think? So the exciting parts, and then what areas do you think need a little bit more investigation?
Yes. So in terms of my specific area, looking at kind of symptoms of psychosis and underlying mechanisms, an area that's somewhat unexplored and we're hoping to get at is studying kind of the phenomenology of hallucinations and delusions, and not just in clinical populations, but also in non-clinical people who have these experiences. So we can actually study the sensory experiences or aberrant experiences without necessarily having psychopathology, and be able to understand better the mechanisms that way. So one of the things we've actually done, and we also have data on the same motion perception task in them, is studying non-clinical voice hearers who have hallucinations and some visual sensory experiences as well. So we're studying them to look at whether this framework applies regardless of a diagnosis or not, and if it's very kind of mechanistic and on a spectrum level versus purely linked to a diagnosis. So that will help us understand better things like distress and level of control that's associated with these experiences.
So when you say non-clinical, does that mean like people who don't have like enough symptoms to be considered schizophrenic, or are these people who are like early stages and might be diagnosed later with schizophrenia or something?
So we're actually studying people who on a diagnostic assessment would not meet criteria for any kind of diagnosis, and not even at risk for or like early psychosis. These are people who simply have experiences of hearing voices.
Okay.
So some of the people we involve in our research are psychics, actually.
Oh, okay.
Yeah, so psychics report mediumship abilities where they get auditory messages, and it's known as clairaudience.
Mm-hmm.
So we're involving some of them in our research, and that's kind of what I was getting at with studying the experiences as on their own without necessarily being linked to schizophrenia or psychosis per se.
Yeah.
And at the same time, people who hear these voices and have, pretty regular level of functioning, they're able to have more control over these voices and lower levels of distress, and not just with voices, but also with other kind of sensory experiences, with visual hallucinations and that kind of thing. So some of the future directions involve studying those experiences more closely.
Okay, that makes sense. Well, thank you for discussing your research with me today.
Sure.
It's been very informative.
Well, thanks for having me.